Thank you so much, Malia. What a wonderful talk and so inspirational. And it's been so wonderful to see our past keynotes come back and speak for us. And I'm honored to introduce the keynote from our second summit, Dr. Spero Manson. Spero Manson is a distinguished professor of public health and psychiatry, directs the Centers for American Indian and Alaska Native Health, and occupies the Colorado Trust Chair in American Indian Health at University of Colorado's Denver's Anschutz Medical Center. His programs include 10 national centers totaling $63 million in sponsored research, program development, training, and collaboration with 250 Native communities, spanning rural, reservation, urban, and village settings across the country. Dr. Manson has published over 225 articles on assessment, epidemiology, treatment, and prevention of physical, alcohol, drug, and as well as mental health programs over the developmental lifespan of Native people. Over the course of his career, Dr. Manson has received numerous awards and is widely acknowledged as one of the nation's leading authorities in regard to Indian and Native health. And we particularly admire his training program of Native investigators. He's been an outstanding supporter and a key advisor on our board for the last couple of years. Please join me in welcoming Dr. Spero Manson.
Thank you so much. I'm a walker. Can you hear me okay if I use this? All right. Well, bonjour. It's lovely to be with you again. I was together with you last year and then in 2014 when we met last together in Bemidji, Minnesota, the land of my people in Anishinaabe. So I want to note that I'm particularly thankful to Ms. Tobacco for her warm welcome to all of our Lakota relatives and to all of you who come from different nations as well. It's a wonderful opportunity to join you again, and I think an important set of conversations. I want to thank Amy and Danielle and Jessica and others in the Planning Committee for the Center for the opportunity to be with you again today. And I look forward as well to our conversations tonight as part of the External Scientific Advisory Committee. This creaks, so maybe I'll try over here. I'm going to take you over the next 30 to 35 minutes and hopefully leave time for questions on a little journey across the landscape that I have been working with and privileged to work with a number of colleagues for the last 40 years. This landscape focuses on the understanding of the emergence and evolution of two major approaches to nature of intervention in terms of healthcare, particularly with our people. On one hand, evidence-based practices, and on the other, practice-based evidence, and some of the issues that have emerged in that context. And it's in that regard, I was particularly delighted to hear Malia note two key notions that I'll be returning to throughout my remarks. The first is the notion of whose voices are heard, as well as whose words are assumed to be true. And the second notion that I think is particularly relevant to my remarks today is this notion about the importance of a discourse on differences. Because I believe, as I will argue today, that in fact we have, just as our counterparts from these other positions, have set up a set of artificial conflicts in terms of our understanding of the notion between evidence-based practice and practice-based evidence that are serving neither very well. And indeed, I'll be sharing a view of that and embodying it within 4 stories. I use the word stories advisedly because they're evidence-based approaches to understanding and to articulating and to documenting the power of a variety of different approaches to practice with respect to health intervention that span the spectrum from practice-based evidence to evidence-based practice. And Justin, whom I'll think publicly now, is going to be moving me through rather than me struggling with the clicker. So Justin, next slide, please. So what's this notion of evidence-based practice? Well, in fact, if we look at clinical work and particularly the biomedical approach, evidence has been critical in a variety of different forms to the improvement of practice and its quality and benefit to those who receive that. In fact, we can look at centuries of work on underscoring the importance of different forms of evidence for improving the nature of those interventions. But really, this phrase emerged about 25 to 30 years ago and became a current one in the field largely in the work of a group from McMaster's University in the early to mid-90s. And it was defined, and I'll use the phrase EBP, evidence-based practice, to characterize a systematic approach to analyzing published research as the basis for clinical decision-making. Then it was a little bit later in the mid to late 1990s when Sackett et al. Published a really seminal article that went further and characterized evidence-based practices as the conscientious and judicious use of current best evidence from clinical care research in the management of individual patients. Next slide, please. In juxtaposition, we have this notion of practice-based evidence that really emerged largely as a response to the increasing focus on evidence-based practice and was driven by a sense from a wide variety of different constituents that in fact this emphasis on evidence-based practice as it was evolving became narrower in its focus, more tightly concerned with very specific ways of knowing and forms of inquiry and the data that merged. I found this lovely quote by Albert Einstein that basically, I think, captures the major tensions that are at work. That not everything that can be counted counts, and not everything that counts can be counted. And it was really the work of Pincus and others that began to fuel this conversation about practice-based evidence appearing in the mid-2000s. And that led to a whole series of conferences that have been increasing in number since 2007 that have focused on the importance of practice-based evidence and introducing this particular phrase. Now, one of the interesting things, next slide please, is that what we come upon is not necessarily a continuum of understanding or characterizing these two views, but we have actually come upon, at present, for the most part, a set of very polarized camps and perspectives that I argue today is actually counterproductive for our efforts. At the heart of this difference is the notion of data. What constitutes the means by which we acquire it, what counts as legitimate in terms of data, and what are the ways in which it should be applied. And I very consciously provided these two images of a spiritual healer on the far left-hand side for those of us working in tribal communities as sort of emblematic of practice-based evidence, and on the right-hand side of a physician, stethoscope and medical chart in hand as emblematic of evidence-based practice. And the challenge we face today is, one, acknowledging and figuring out ways to have this discourse on difference between these polar views. So I'd like to take you through 3 stories of examples of work that I've been privileged to be a part of over the last 25 to 30 years that illustrate the fact that this is a spectrum, not polar views. All right? And a couple of caveats about this. First off, it's in the context of alcohol, drug, and mental health problems or behavioral health. Although I could do it with respect to diabetes prevention and treatment, as well as cardiovascular disease and prevention and treatment with respect to tribal people. But I think it represents a more coherent tale to do it within this context. And I chose behavioral health because for those of us working in that particular field, there is a very concrete set of outcomes in terms of policy, finance, and structuring of reimbursement available to us, as is not the case in these other thematic areas. So next slide, please. The first particular example is on the far left. If you imagine and can remember the photo of the traditional healer under practice-based evidence, it was in the context of the Vietnam veterans study that I was honored to lead back in the mid to late 1990s. That particular study was a replication of something called the National Vietnam Veterans Readjustment Study, which focused on African American, Hispanic, and white men, essentially, who were combat veterans and returned, and attempted to answer a series of questions about the nature and extent of the suffering that they experienced due to combat exposure in Vietnam. And it was asking several other questions about whether or not something, quote, post-traumatic stress disorder, end quote, is in fact a definable, reliable, valid construct diagnostically. It was asking what was the nature and extent of the experience of post-traumatic stress disorder among these veterans. Thirdly, what was the consequence to them and their families? And ultimately, how well our systems of care were prepared to address those concerns. The answer was, in short, that yes, in fact, post-traumatic stress disorder could be reliably and validly identified diagnostically. Secondly, that it had substantial impact on those particular veteran groups. Thirdly, that it was related to many other kinds of emotional and psychological problems and had enormous consequences for reintegration to their families and communities. And lastly, that the nation as a whole and the systems charged with the responsibility for addressing those concerns were woefully ill-equipped to address them. And this particular study was a replication of that, focusing on American Indians together with several other racial and ethnic minorities, notably Native Hawaiians and Asian Americans, Japanese Americans specifically. And in a nutshell, there were two major tribal groups, two of the largest of the three largest reservation-based tribal communities in the country. The Lakota, represented by Cheyenne River, Rosebud, and Pine Ridge, and in the Southwest by the Navajo. And in working through with this with the Navajo, we had the opportunity and the luxury of focusing on issues of measurement in terms of the adaptation of the original measures from the study, as well as license to identify additional measures that had good promise for providing us insight into the nature of the risk, onset, severity, and course of post-traumatic stress disorder in these tribal communities. And we identified a series of tribal cultural constructs that had not been anticipated, as one might anticipate in the original study. And we examined those constructs very carefully. And you know, as a part of being a partner in community-based participatory research, if your partner encourages and requests that certain kinds of questions be asked, you need to honor that. And among the questions that the Navajo asked me to address was, in fact, the nature and extent of the use of traditional ceremonies on the part of these Navajo combat veterans. Secondly, what the cost of those ceremonies were to the veterans and their family members and community. And thirdly, what were the outcomes related to that? Now, let me tell you, as a living in both worlds, as an American Indian and as a scientist, this really presented an internal conflict for me, because I did not necessarily assume the tools that I have as a Western-trained scientist lent themselves well to understanding the epistemologic foundation and sources of efficacy of Navajo traditional ceremonies. But I took that challenge on in deference to our tribal partners. And in fact, I'll just share with you, I have photographs of me out there at some of the various ceremonies, counting the number of sheep that were given, counting the number of woolen goods, counting all of the different kinds of things, part of the reciprocal change between patient, family, and healer, the Hatle or the singer, for the offering of these ceremonies. There were basically 13 of them that were identified. What did we find? First off, we found that there was remarkable participation by the Navajo Vietnam combat veterans in these tribal ceremonies prior to deployment to Vietnam and ultimately upon their return and reintegration into the community. I actually spoke to you about this a little bit several years ago when we were together in Bemidji. But very importantly, what we found is that not everybody did. It was about 50-50 of the some 350 to 400 Navajo veterans who participated in that part of the study. And so we were able to compare, for example, pre-deployment, those Navajo veterans who participated in any one or more of those tribal ceremonies versus their counterparts who did not, controlled for the level of exposure to the critical variables, in this particular case, actual involvement in combat, and found that upon their return, that those who did participate in the tribal ceremonies prior to deployment had substantially less post-traumatic stress disorder than their counterparts who did not participate in those ceremonies. We also were able to document unequivocally that even if they did meet criteria for post-traumatic stress disorder upon their return, that the nature, extent, severity, and course of it was shorter and less severe than their counterparts who did not participate in tribal ceremonies upon return. And coupling that set of findings together with the economic data, if you will, the counting the sheep, the woolen goods, all the other kinds of gifts that were exchanged as a part of each of these ceremonies, we were able to develop a schedule that paid out basically $75 for a 1-hour blessing way at one end of the spectrum and $750 for a 2-week enemy way ceremony. And that and the other ceremonies and their monetization between those two endpoints serves as the basis for a schedule that the Veterans Administration used and signed in a memorandum of agreement in April of 1998 with the Navajo Nation to begin a reimbursement process so that to this day, the VA reimburses the Navajo Nation for the performance of any one of those 13 tribal ceremonies based upon that compensation schedule. That's pretty remarkable, particularly for conservative bureaucracy such as the VA. Now, it wasn't for matters of social justice. It wasn't for matters of altruism because they thought it was the right thing to do. It was because we had the evidence that participation in those tribal ceremonies made a difference in risk, onset, course, severity of this particular condition, and it had economic consequences to the VA. Those are exactly the kinds of questions that are of concern in evidence-based practices that are examined broadly. So this is, to my knowledge, the only example we have today of a practice-based evidence in which something of this nature, wholly unadapted in any way, shape, or form, has had the evidence generated to permit or to encourage or to allow another agency to reimburse, which is the most critical, I submit to you, litmus test. It's reflective of Biden's comment about value and budget. All right? So that's story number one. And it continues to this day, and it's had rippling effects on many other tribal communities. For example, we have a very active telepsychiatry program in 13 tribal communities around the country. The original efficacy and work of that was funded by LSAO's Institute. And the VA has found ways in which to compensate for traditional healing support and resources in those other communities, which of course vary from the Navajo example. Next slide, please, Justin. The second example, now moving us from the far left towards the right-hand side, but I'm still on the left-hand side of the middle, is an approach that doesn't necessarily begin with the indigenous practice itself, but recognizes that the cultural construction and understandings, the processes and procedures to addressing certain kinds of conditions, in this particular case, in Walking On, substance abuse among adolescent Cherokees, can be taken and can inform directly, in a very systematic way, an intervention. And this is the work of colleagues from our center, led by Dr. Novins and colleagues from Cherokee, in which they took an explicit and explicitly blended traditional Cherokee healing and spirituality within a science-based practice and melded it with cognitive behavioral therapy and contingency management and modularized this and pre-tested it and then did reliability and validity work to demonstrate its outcome. Now that's one step away from taking an already existing practice, but using this kind of cultural perspective, knowledge, and set of mechanics to develop and deliver and to evaluate an intervention. Still on the side of practice-based evidence from my point of view. And it has its counterparts today in the work of many others. For example, Jim Allen and Stacy Rasmus and their work with the Yupik people and developing suicide preventive interventions up there, etc. Next slide, please, Justin. This is the third story. And this takes us a little further even from the left to the right. Think of it as 3/4 of the way along that spectrum towards the evidence-based practice whole of it. Now, chronic disease, as was anticipated in particularly the earlier presentations, has been replacing many of the infectious and communicable diseases that we native people face. Largely as a consequence of several things: the success of Indian Health Service and tribal programs in terms of large-scale public health initiatives, vaccination, sanitary engineering, et cetera, et cetera. And as a consequence of the increasing life expectancy, we now are at risk for a whole host of chronic diseases that otherwise were not necessarily as prevalent 30 to 40 years ago. But a constant companion of chronic disease, diabetes, cardiovascular disease, rheumatoid arthritis particularly, is pain, as well as higher risk for depression and anxiety. Okay? Those diseases represent enormous risks to us in terms of compromising our sense of efficacy, our ability to deal in desired ways with the world around us, etc. So, in the late 1990s, I launched a study with 3 tribes in the Pacific Northwest, the Nooksack and Lummi, the Warm Springs tribe, and we took something called the Coping with Depression course, which is a standardized, highly efficacious, evidence-based practice developed by colleagues, Peter Lewinson and others at the University of Oregon at the time, and subsequently adopted by many. And we took that, which is basically a 16-session or 16-module approach to transferring certain kinds of skills, perspectives, and knowledge to the participants, to the patients in their form, to enable them to become less likely to experience depression and to move to full-blown major depression. It's built upon Albert Bandura's notion of social learning, and that is, as you interact with your environment, the more negative that environment is, it has adverse consequences for one's behavior, thinking, and feelings. Well, this particular set of interventions, the intervention is set in a psychoeducational context, which means it's to be taught. Secondly, it's very skill acquisition oriented. So things like covert rehearsal or progressive relaxation techniques are part of the tools of this particular approach. So what we did is we took the very classic conventional forms of progressive relaxation technique, found what their counterparts were at that point in time within the tribal communities, and there were clear analogs to those progressive relaxation techniques, such as sweats and other kinds of mindful-like activities. And we reframed those particular skill acquisition activities within the local vernacular and form. Covert rehearsals is another part of cognitive behavioral intervention. And we found examples, cultural analogs, if you will, within each of those tribal communities that was the vehicle for communicating and enabling the participants in this intervention to engage in covert rehearsal. Now, I was told at the outset that you can't have men and women, particularly older men and women from these tribal groups, coming together in these kind of therapeutic groups. Well, you know, for those of you who know me, it takes a lot to make me believe otherwise. So what we did was we took this Coping with Depression course, destigmatized it, called it the Preventing Stress course. We went into the local tribal colleges. We got it officially credited as a 16-week course. The person who delivered it, retired community health representatives, were teachers. The patients, the older men and women, 8 to 12 of them at a time in each course, were called students, not teachers. We compensated them, but they didn't know it because we characterized it as tuition remission. They got $10 back from a $120 scholarship that the tribe originally gave each of the student participants. And the impact was phenomenal, both in terms of the process and outcomes described here. And we were able to demonstrate, one, that you could do this in ways that we have been told you could not, that you could translate with appropriate focus and an energy and criticality the key concepts of this particular intervention that derive from a very particular Western set of theories into terms and processes and procedures that could be readily translated into the local circumstance. And the outcomes were so demonstrable that the local tribal health programs at Indian Health Service began to give older adults, upon the diagnosis of a chronic health condition, free tuition to the local tribal college to participate in this particular course, which is continuing today in 2 of the 3 tribal colleges. So sustainability is absolutely critical. And so we have to think about those things at the same time. Next slide, please, Justin. The 4th example is now way over on the right-hand side under evidence-based practices. We are able to implement evidence-based practices even if they don't initially take root within our own tribal views, cultures, and perspectives in ways that are very powerful and that can have benefit to our tribal communities and people. I think the best example we have today is the work of my colleagues and ourselves up at the South Central Foundation at the Alaska Native Medical Center in Anchorage, Alaska. Now, the South Central Foundation is the provider of the outpatient services, largely under the rubric of the primary care center, which is the other half of the inpatient services overseen by the Alaska Native Tribal Health Consortium. And in 2001, we began together something called a depression collaborative, in which we took standard detection and management techniques, now often referred to as SBIRT, Screening, Brief Intervention, Referral for Treatment, SBIRT, which is a registered evidence-based practice that is available for financing by CMS and other entities. And we took that model and we applied it to depression. And to date, we've screened over 80,000 unique Alaska Native and American Indian patients through that particular facility. And we identified the following. We identified, we used the PHQ-9, which is one of a series of choices to us for depression screening. We identified 27% of the patient population 18 years of age and older who were seen during that period of time as meeting criteria for concern or various levels of increasing severity of depressive symptomatology. That became the trigger for a warm handoff so that the primary care provider in the exam room upon the completion of the screening would see what the score is and would immediately page a behavioral health consultant, purposely called that to destigmatize this notion of psychological intervention or psychotherapy in the healthcare setting, who would come, master's level clinician, greet the patient who is identified at risk, take him or her off into a separate exam room, spend about 7 minutes with them, do a motivational interview, set up an educational process, and do a contract so that he or she, the patient at risk, would be engaged and thus involved in a series of possible increasingly intense interventions as appropriate to his or her circumstances. Now, of that 27% of nearly 80,000 people, 91% had never told their primary care provider previously about any kind of emotional psychological problems. They were totally undetected. And we did a random survey of the medical records to confirm that from the provider's point of view. This initiative was so successful in identifying early and addressing in the very beginning stages of the depression that we decreased service utilization because individuals suffering from depression are typically high utilizers of primary care. We decreased inappropriate utilization of the other healthcare services. It was so successful that the state of Alaska revised their CPT codes so that their Medicaid reimbursement now became possible, and it's sustained to this day. And we went from 4 behavioral health consultants in that clinic in 2004 to now 32 of them in that clinic, 1 assigned to each of the primary care teams. And along with this went very rigorous and wide-ranging evaluation of a rigorous scientific nature to document this. And we continue that in order to be able to continue to justify this. Each of the stories that I've told you have probably anywhere from 4 to 10 or more different publications in scientific journals to document this. Next slide, please. This is my last slide. Why is it important, in particularly in the behavioral health field, to do this, whether it's way at one end of the spectrum with respect to practice-based evidence or at the other with respect to evidence-based practice? It's because through the efforts of the Substance Use and Mental Health Administration, SAMHSA, we've had for the last 10 years something called the National Registry of Evidence-Based Programs and Practices, NREP. Why is that important? The features of which are described here. I'll not bore you with characterizing that. But it's important because, one, SAMHSA requires the use of interventions that appear in this register in its grant-making activities. All right? That's the first thing. So if you're in a tribal community and we don't have either practice-based evidence or evidence-based practices on this registry, we can't use it in our applications for funding to SAMHSA. The second thing is that increasingly other payers from across the country are looking to this registry as the basis for allowing the services provided through such mechanisms to be reimbursed. So this is pretty critical. We don't really have the same endpoint with policy and financing implications in any other arena other than this one. So the question is, how do we move beyond this tendency to polarize the discussion? How do we move to a discourse on differences that will allow us to respect that although there may be different voices, that the words of those voices can be equally potent and hold promise for providing us with insight into these very matters. And I argue that we can do that with the tools available to us, as limited as they may be, in their application to these kinds of issues. And I encourage us to pick back up that conversation and to figure out how to engage our colleagues, that we not, as a number of very vocal and well-respected scholars in our tribal communities are arguing in an either-or kind of fashion, that it is not an either-or set of circumstances. And that if we do pursue that conversation in that fashion, we lose. And others lose. Thank you very much.
And we have some time for questions.
Dr. Manson, I read that you're Pembina Chippewa, so you're enrolled in Turtle Mountain?
Up at Belcourt, yep. Twyla Martin Kikab is my first cousin.
Okay. I brought my husband in to introduce to you. I truly believe what you did with the Navajo Nation works, because I'm also a counselor. So I work with a lot of traumatized children, traumatized adults, and those that use alcohol in general proceed from go into alcohol because of traumatization of some kind, which is very, very prevalent on reservations, and all the way from sexual abuse, physical abuse, domestic abuse, all kinds of traumatization, and it affects our schools and our children. Well, what I found was my husband was a Vietnam veteran, and his PTSD was horrible. It came very close to causing a divorce. But somehow he found the native spirit. He was a Christian, and he found the native spirituality worked. He started doing sweats, he started doing sun dances, and he came out of it. He didn't go to treatment. Later years he said he should have, but at that point in time he picked up the pipe and he became a Sundance leader. And he influenced a lot of other veterans. Okay? Now he's passed, And luckily, I found this guy. Anyway, he's, we're
I'm
both...
sure you say he was equally lucky if he had a chance.
He better. Okay. Anyway, he is a traditional man, and so am I. He does sweats. In fact, we had a young man that wants him to sponsor and wants to come into the sweat and learn how to build a sweat. He goes to AA. So we're going to work with that young man. Well, he's going to work with that young man. And so part of the sweat process, somehow you have it up in Belcourt. You have a lot of sweat lodges if you ever want to do some more research. Anyway, we also have a lot of sun dances. But in our sweat lodge, you can gift, but it's not cheap. I mean, it's more like a blanket. Okay. And then sometimes in thankfulness, like they'll give a giveaway. In East and the West, they call it a potlatch. Okay, so we have these big giveaways. Okay, and we give to the people, and we feed the people, and we have these big meals. Okay, and that's how we get together. And I have fed around 200 people at a time sometimes. And so we have these sweat lodges and people come up there. But at this point in our lives, we're very worried about it, that it's not going to get passed down. So we're trying to get young people involved in learning how to build the sweats and conduct them, and women involved. And so I don't know about in other nations, but in our nation, women can hold their own sweats and all of this. But it heals people, and I'm a witness to that. I'm a true witness to that. And Robert can tell you that people have got, and we can't talk about what's going on in sweat. What stays in Vegas stays there. Well, what stays in sweat stays there. So he does sweats, and I do the cooking for the sweats. We assume that they fast before the sweat, so I cook soup and bread and stuff. So after the sweat, they can come out and eat. And but it's not just going into the sweat that I'm telling you about. It's like part of the process of healing is learning how to build that sweat, learning about all the terms that are included in the sweat, learning about the protocol in the sweat. There's a protocol to sweats. There's a protocol to sun dances. They're not just mishmash. They're,
I have two thoughts, if I can react very quickly. Thank you for sharing
and so
that.
I wanted, later maybe you can talk to Robert, and he can tell you about sweats. And the other thing I want to say is I agree with the suicide intervention by community-wide, because in 1983, in the school, we were having problems, and so we built our own suicide protocol, and we used it until now. And we've had maybe in 30 years 2 teenage suicide, but a lot of attempts, a lot of ideation. But here's where I'm going with that. The community, Dr. Paul Dufresne brought us together, and he's going to have a community-wide, they're going to use the CSSR-S, I think, and that's going to be community-wide. Police, hospital, mental health, schools, wherever we can get it. The last step is in place right now. We have to get the tribal council to approve it. So, and I think that'll have the same effect as that study. Where was that, in Alaska?
Which one?
The one on suicide where there's community-wide?
Oh, that was in Alaska.
Yeah. So,
well, please give my regards to Paul. He's a dear friend, former coworker, and just a delightful human being. I have two thoughts. First off is, as was implied in your comments about, I think it was in regard to your husband's experience of post-traumatic stress disorder, the myth at work has been, for the most part, that if a Native person participated in tribal ceremonies, they were not going to participate in their biomedical alternatives. Really firmly entrenched, both among Native scholars going back 30 years, as well as other work. Absolutely not true. I'll never forget when I was in Hopi, when I first started out 40 years ago, and I was asking a Hopi gentleman about, the range of services, or it wasn't even the word services because it didn't make sense to talk about the traditional resources, healing resources in those senses. But I asked him as he shared with me all the different kinds of things he availed himself of to address his, in this particular case, very serious endogenous depression. And I said, well, how did you do this and then do that, and why did you do this? And he turned to me and he says, young man, I'm pretty smart. I know to cover all my bases. And, we really have multiple help seeking, and these are not mutually exclusive kinds of resources. The second thing that I want to share is that I also did work with the Puyallup in the Pacific Northwest, and there we were looking at how to understand and to compensate their traditional healers, which the availability of compensation was through Blue Cross and Blue Shield. And once we were able to document the impact that these traditional healers had for their patients, Blue Cross Blue Shield said, okay, well, we'll do X number of dollars for that, Y number of dollars for that, Z number of dollars for that. And I said, no, we don't want to recapitulate what's happening with the Western healthcare system. Mm-hmm. We'll take the dollar equivalent and we'll purchase the woolen goods. We'll purchase the tobacco. We'll purchase the other things. And that patient will be given it physically to hand to the traditional healer. And what that does is reinforce and reaffirm the reciprocity that I firmly believe is absolutely at the heart of the therapeutic alliance in the process of healing, whether it's biomedical or traditional in our respective communities. And I submit that one of the challenges we face today in our financing of healthcare is that we have broken that connection for the most part. And there is not the sense of reciprocity and mutual affirmation that we once had and that we still do in tribal communities. So those are two things that come to mind in your remarks.
And then another tribal that's translated into Native nations is the Red Road.
Yes, of course.
Like, in Mahnomen, they have a wild rice roundup, which I was privileged to go to, and it was amazing.
And of course, among the Navajo, it's the corn pollen path. Among Anishinaabe people, is Pismadedewen, the person of integrity, and the different kinds of markers and events that chart your successful journey along those lines. You're absolutely right. And it's returning to understanding those views and what they imply for health and well-being throughout the developmental life course. Thank you for sharing that. I look forward to and be honored to chat with you afterwards.
Great. Can we take one more question before we wrap for lunch?
Up to you.
I'll make it quick because I know everybody wants to eat. Anyways, hi, my name's Kathy Denman-Wilkie. I'm from the Saginaw Chippewa Nation, but I work in St. Paul. And we'll be presenting later. We're one of the pilot grants. But I just want to thank you for the work that you're doing. This is a major conversation within the St. Paul Indian community right now as we struggle with our grantors demanding that we use evidence-based practice, to the point that leaders in all of our agencies have done a resolution that we're taking to the Ramsey County boards, that we're taking to Department of Health, Minnesota Department of Health, trying to get them to understand that we want culture and best practices to be apart. But I do see there's a division sometimes between the agencies thinking it has to be either or and that it can't be. So one of the things I wanted to just say is there's not enough research of this kind to support our work, so I appreciate the research that you're doing, but there needs to be more of that research. And that it's not, I think we have to think about our smaller nonprofit agencies that really don't have the money. They're doing the practice, they're making the changes, and we'll talk about some of those changes today. But we're seeing the changes through those traditional practices, but we don't have that type of money to hire an evaluator at $30,000, $40,000 or whatever these evaluators cost. You know, to do that kind of research that is needed to prove that we're making the changes.
Well, let's talk, because I
And-
think it could be done much more cheaply than that, and I think you can build it into your
Right.
clinical practice.
Right. Yeah, and that's what I think we need more help with, is how to do that and how also to get our agencies to not have it be an either or. You know, because they know that traditional practices work. We know that. But how to say, how can we take both and make it work? So thank you.
Thank you all.